Today, I'll be presenting our recent publication in the Journal of Neurointerventional Surgery journal with the title of Vis Elvo versus Rapid Elvo in the Detection of Large Vessel Occlusion on CT Angiogram, which was published in June of this year. So these packages, the Rapid and Vis Elvo, have been previously evaluated independently. To our knowledge, this is the first direct comparison of these two software packages on the same data set at two comprehensive stroke centers. So as we know, the mechanical thrombectomy is the standard of care for patients with ELVO and very soon MEVOs and DEVOs. And previous studies have shown that AI can decrease door to puncture time by earlier notification of the neurointerventional physician. So this is a study published by Dr. Hassan in the Journal of Stroke. It was a retrospective one, and it demonstrated that the introduction of Viz AI to their hospital resulted into significant improvement in treatment time within the comprehensive stroke center, as well as significantly higher rates of adequate reperfusion. Another study by Dr. Hassan published in Interventional Neuroradiology. This time it was a prospective one, and again it demonstrated that the introduction of Viz AI to their health system resulted into improvement in transfer times for ELVO patients, as well as a reduction in the overall hospital length of stay and length of stay in the neuro ICU. So these are the most common commercially available AI in the market nowadays, Viz and Rapid. And as we know, they're FDA cleared and intended to detect occlusions in the M1, MCA, and ICA. How does Rapid algorithm work? To my best of understanding, it first removes the bone tissue based on the location and brightness of the voxels. Then it measures the blood vessel density compared to the contralateral side. And the ELVO alert will be triggered if there is 40% or more reduction in the blood vessel density. So whatever you can see here in red and yellow. Viz on the opposite side Viz will receive the CTA, the original CTA. Then it will remove any scans with metal, poor bolus timing. It will remove the bone tissue, and it will perform the soft matter extraction, as you can see here. Then it will perform a geometric transformation to make sure that all the images have the same orientation. Then it will perform what they call the vessel segmentation and extension. So Viz have trained two neural networks. The first one will segment the M1 MCA. The second will provide the whole vessel segmentation in the relevant area. Then it will combine both to form the MCA3. Then it will perform what's called the vessel tracing. So you can see the AI here will trace the vessel until it ends here. So it reaches a dead end. When it does the same on the right side, it will identify an occlusion. However, it will still not consider this a positive ELVO study. It will combine the tracing that I just explained with, it will compare the Hounsfield units, right versus left. And it will combine it with the segmentation that I have previously explained. Combine it with multiple other quality metrics to form a single score called the ELVO score. And this is the threshold. So whenever the threshold, the ELVO score has been reached, this is when the study is considered to be positive for large vessel occlusion. And the idea of combining all these algorithms is to minimize the chances of having any false positive results. So how did I end up having access to both? So Rapid AI was initially available in our health system. Then Viz AI was slowly introduced in our health system in different dates in each hospital in 2022. And due to the overlap in contract and the transitioning from Rapid to Viz, some patients have the chance to be evaluated by both Rapid and Viz. So obviously, these are not the total number of CTAs we have performed in these hospitals, nor the total number of large vessel occlusions we have. However, these are the only patients that had the chance to randomly have both Rapid and Viz performed on. So that's those are real life example. Um, as you can see on the top left, this is a CTA processed by Rapid, and it will say that it did not detect any LVO, so it's a true negative study. Viz concurred with this, it no suspected LVO, and the final radiology read comes back negative with no large vessel occlusion. So that was the essence, the base of our study. So we basically had the CTAs and we compared the result from Rapid versus Viz versus the gold standard final radiology read. That's another example. However, as you can see, Rapid suspected LVO on the left side and Viz concurred with it. And we compared this with the final radiology read, which reported to have a left M1, M2 occlusion. So at that time, when I had Rapid and Viz, at that time, the only one way to have a notification for the studies from Rapid, I'll receive an email. I'll have to go check my email, and then I will have this picture or suspected LVO. Then I'll have to open the app. On the opposite side, whenever we have a suspected LVO from Viz, you probably are familiar with this sound that will alarm you of a positive LVO. However, I noticed that with the rest of the team that there is sometimes discrepancy between Viz and Rapid. So that's again real life examples. On the top left, you can see that Rapid suspected an LVO in this study. However, Viz did not detect an occlusion, and the final radiologist read came back with no large vessel occlusion. So there was discrepancy between both Rapid and Viz. That's again another real life example of our patients. And then you can see that Rapid suspected LVO on this, and Viz did not suspect an LVO. And the final radiologist read concurred with Viz that there was no LVO. So I've noticed that this have been happening more and more whenever you have heavy calcification around the cavernous ICA. So as we know, and this has been previously published, that the large numbers of false positive results or values can lead to alarm fatigue, overwhelm the physicians, delay the reads, or ignoring the whole AI system. So I had access to 3 comprehensive stroke centers and 1 mechanical thrombectomy capable. We extracted the data in 2022, and we're able to collect a total of 360 patients, which had randomly had the chance to be evaluated by both Rapid and Viz. The mean age of these patients were 65 years old with 160 males. Among these, only 47 have been confirmed to have a large vessel occlusion. So before we get to our results, let's show you what has been previously published. So the previous version of Rapid LVO, at the time of our study, we have a newer version of it. This version has been evaluated independently, and it demonstrated a high sensitivity, high specificity, high negative predictive value with a positive predictive value of 0.58. Viz, on the other side, also has been studied in the past, and it also demonstrated a high sensitivity, high specificity, high negative predictive value. However, it has a positive predictive value of 0.65 when compared to rapid. And at the time we have performed our study, we had newer version of rapid and viz. So what were the results? Our results were matching with what was in the previous studies regarding the specificity, sensitivity, and negative predictive value. So both rapid and viz had very high specificity, sensitivity, and negative predictive value. The main difference was in the positive predictive value. Rapid positive predictive value was 0.46 when compared to 0.75 for viz, and this was strongly statistically significant. What does a positive predictive value of 0.46 mean? It's almost like flipping a coin. That means 50% of the studies that are alarmed to be positive might be true positive versus not. So we performed a contingency table, and this will show you viz versus rapid. Both were correct in 300 patients. Both were incorrect in 14 patients. Rapid was correct in 6 patients when viz was incorrect. However, rapid was incorrect in 40 patients when viz was correct. So we performed a confusion matrix, compared rapid and viz, and you can see rapid on the left, and it was correct. It excluded an LVOR 265 patient, identified an LVOR 41 patient. However, it was incorrect in 48 patients when compared to viz, which was incorrect only in 14 patients. So we performed, we tried to figure out what could be the reasons resulting into a false positive result. And we performed a logistic regression on multiple factors. And we found that a low ejection fraction or a high-grade intracranial atherosclerosis, according to the modified Woodcock score, can result into a false positive study in both viz and rapid. So what is the conclusion? Conclusion was that rapid LVO produced a significantly larger number of false positive values when compared to viz. The false positive values can be a source of alarm desensitization, leading to missed alarm and what we call the alarm fatigue. And we hope that these data can be used to provide insight into the causes, the predictors of incorrect classification, like the ejection fraction, the intracranial atherosclerosis, and will improve future versions of these algorithms. Thank you very much.